Okay, let's start our webinar. So first, I would like to welcome you all to today's webinar on exploring the missing pieces of health worker mobility data in Europe. This webinar is organized by the Pillars of Health Alliance. This is an alliance of EU-based organizations who aim to contribute to an equitable geographic distribution of health workers across the European Union, to also ensure that all European citizens have equal access to health workers. And the partners within this alliance are Wemos. Wemos is the lead organization, the Center of Health Policies and Services in Romania, VDAA in Germany, and the VU Athena Institute in the Netherlands. My name is Marlies Visser. I am a researcher at the Athena Institute at the VU University in Amsterdam and researcher within the Alliance. Great to see you joined us today. Before we begin, I'd like to make some quick remarks on the format of today's session. After the introduction, I will present on our key findings from the cross-country analysis report. And after this presentation, I will introduce our panelists of today, who are Gaetan Lafortune and Professor Ellen Koolman. So they will join the panel after the presentation to engage in a bit of a reflection on the data, on the trends that we see, discussion on the key gaps in the data, as well as visions for the future. So I will introduce them after the presentation. I'd also like to remind you, if you have any questions for the speakers, you can send these to us through the Q&A box. We'll be moderating this box throughout the webinar, and some questions may be addressed at the end. So with that, let me start by presenting some of our key findings of the cross-country analysis report. Yes, so I will present the key findings based on the data between 2010 and 2022. So the report is based on secondary and publicly available data from the OECD Health Statistics Database, as well as the European Commission's Regulated Professions Database. The data was retrieved in September 22. And in addition, a key footnote to this analysis is that we focus specifically on countries within the EU and the neighboring countries. And of course, there is significant contribution of health workers from countries outside of this area, but this is not the focus of this presentation. So our analysis did include countries for which data was available within the EU, European Economic Area, Switzerland, and the UK to illustrate these migration patterns. So, given that the mobility of persons is a founding principle of the EU and recognizing the right of health workers to migrate and seek opportunities elsewhere following these labor market demands, international mobility can improve career opportunities, it can offer better working conditions to health workers and present on a system level solutions to health worker shortages in some countries. We also see that when large numbers of medical doctors and nurses emigrate, following these labor market demands, this may then contribute to actually weakening the capacity of service delivery in sending countries and threatening their health systems, as well as having the potential to undermine universal health coverage. And this is particularly identified in Southern and Eastern European countries. And to tackle this challenge, it is vital to understand these dynamics of health worker mobility through data collection, data monitoring, and data integration. And this is with our work within Pillars of Health is something that we set out to work on, to say, what can we say about these mobility patterns from the last 10 years? What progress has been made so far in collecting this data? And what are the missing pieces of this data? So, before moving forward, I do like to stress the definition of health worker mobility that we use in the report, which is on the slide. It's the movement of health workers, permanent and temporary, that crosses national and regional jurisdictions. So with that being said, I'd like to start to focus on the reliance on foreign trained health workers. So the reliance can be understood as the share of foreign trained health professionals, so doctors and nurses in specific, within a country's health workforce as percentage of the total workforce in a specific country. So this share can be calculated by the amount of doctors who have obtained their first medical qualification in another country and then are entitled to practice in this preceding country. And we will give some insight into the reliance on foreign trained medical doctors and nurses in 2021, as well as some of the trends. And to do this, we use the OECD health statistics. So looking first at the reliance on foreign trained doctors, what you can see on the slide is a table, which is a bar chart on the dependency on foreign trained doctors. And in yellow is the data from 2010, and in green is the data from 2021. And we identified a general high reliance among countries such as Ireland, 40%, Norway, Switzerland, and the UK. And that's up to 42% in Norway, which is quite high, as this is towards almost half of their share of doctors. And when we look at these differences between the yellow and the green bars, we see that actually over time, this reliance is observed to increase. So in Germany, Norway, Switzerland, for example, we see an increase from 7 percentage points towards 13 percentage points. Moving on to foreign trained nurses, we can identify a somewhat similar pattern in that the reliance is also high in some countries, such as Ireland, 46.5%, also a high reliance in Switzerland, and UK and Austria. So a note here, Ireland is not in the graph. You cannot find it because there weren't data available for around 2010 and the years around that year. But I did want to share that they have quite a high foreign trained nurse reliance. And in general, while the percentages are a bit lower as compared to foreign trained doctors, you do also see that in most countries, this reliance on foreign trained nurses is also increasing. And what I do want to say with this is that this indicator of foreign trained doctors and nurses, it consists of both native born and foreign trained and foreign born and foreign trained health workforce. And not for all countries, this data or this differentiation was available. But for what I will say, for some of the countries that show a high dependency, we also identified quite a high proportion of foreign-born workforce. So in general, we see in some countries, specific countries, a high reliance and an increasing reliance over time. In addition to this, we also in our report aim to understand more these mobility patterns between and within European regions. So where do these health workers come from? To which country do they seek to migrate? Do they intend to migrate? And we did so by looking at more the regional patterns between European regions. These regions were based on the United Nations division of European regions. And then also specifically looked at more individual countries to compare them with one another. For this, we used the European Commission's Regulated Professions database. And to say something about this, so within this database, the indicator that is being used is recognition of qualification. And this indicator means a host country's decision on a health worker's request for recognition of qualification in that country. So this health worker may have obtained their qualification in another country in Europe and then seeks to recognize their qualification in host country. So important to mention here is that, so this says something about the amount of times or the amount of qualifications that were recognized, but we do need to be cautious as it might be that this is not the reality of migration. Whether these doctors and nurses then actually migrated, this might still be a question. Then we might also get into this later in the panel. So On the slides, I first want to get a look at the medical doctors. You see a Sankey diagram with flows from left to right, and these flows basically indicate the absolute amount of doctors and nurses seeking to get their qualification recognized in another country, which may be either in the same region or maybe in a different region. And looking at these flow diagrams, we can see that the countries or regions from which doctors send most of these requests are sent actually from Eastern Europe and then Western Europe and Southern Europe. And most, on the other hand, on the right-hand side, most of these requests are then received by Northern European countries and Western European countries, while a limited amount of requests are received by countries within Eastern and Southern Europe. And we also included a comparative analysis of countries. I did not include that in this presentation, but you will find it in the report. And I did want to highlight some of the countries, as we identified that within this figure, the countries from which the medical doctors send most of their requests are Germany, Romania, Italy, Greece, and Poland. And then they are most often received by the UK, Switzerland, Norway, Germany, and Sweden. And Germany and Romania being the biggest ones, and the UK receiving the most. Then looking at this for nurses, we actually identify a similar pattern in that we see that, again, most requests are sent from Eastern and also Southern Europe, and they are to a limited extent received by these same regions, while, again, Northern Europe and Western Europe receive most of these requests for recognition of qualification. And before I go into the specific countries, I already want to mention that it is interesting to see that on the one hand, we see that Southern European countries and Eastern European countries are the countries from which most requests are sent, and most of them are received by Western and Northern Europe. But looking at the amount of requests received by Western Europe and Northern Europe, we also actually see that a lot of these requests come from nurses and doctors within that same region. So that explains these large blue and large orange flows. And this actually, looking at the doctors, was also the case. So here again, you see that for the pattern for doctors, there's actually quite a large contribution of requests received by Western Europe coming from doctors from Western Europe. So going back to the nurses, we see that in these flows, Romania, Spain, France, and Italy, and Portugal, from these countries, these requests for recognition are sent, while they are received again most often by the UK, followed by Switzerland, Norway, Germany, and Belgium. So from that, we identified, so from this data of recognition of qualifications, we found two compounding patterns of intended mobility. So again, this doesn't necessarily say something about the reality of migration, but it can say something about their intended mobility. And we see that health workers intend to migrate from the Eastern and Southern European regions towards Northern and Western regions, and health workers intend to migrate within Western and Northern European subregions, while these Northern and Western regions actually appear a key contributor to the inflow and outflow in these regions. And possibly, of course, this may be due to similarity in their languages, similarity in cultures, as well as densely populated border areas, which may contribute to this migration between neighboring countries. So it is, however, important to mention here that these analyses that I just presented is based on absolute numbers of medical doctors and nurses seeking to get their qualification recognized abroad, and may say little about how this relates to that same country's total doctor and nurse workforce. and considering the varying amounts of, or the levels of doctor stocks and level of nurse stocks across countries. Also the relatively smaller flows or smaller requests or lower amount of requests may still contribute quite significantly or impact the national health system in some countries quite significantly. For that reason, we also looked at this intended outflow relative to the country's average national health workforce. So for that, we used outflow data from the regulated professions database, and then the average national health workforce data from the WHO Global Health Workforce Statistics. And doing that, so calculating this outflow and divided by their average amount of medical doctors or nurses, we can see that, for example, Estonia, Denmark, and Romania for doctors, they show the highest magnitude of this outflow, which is over 25% over these 10 years. So if you divide it by 10, it may come down to, on average, around 2.5 to 0.7 or a bit over 3% of their health workforce in terms of doctors. And looking at the outflow of nurses, we see a higher magnitude also again in Romania, in Portugal, and in Denmark. And we did check for the inflow that then came into these countries. And specifically for Romania and countries like Estonia, Slovakia, this remained quite low, meaning that this impact may really be there, while for Denmark, they may receive some health workforce as well from their neighboring countries, such as from Germany or from Poland as well. So to sum up some of our key findings from this secondary data analysis is that we see that there is this persistent popularity or indications of persistent popularity of certain EU countries and high resource EU neighboring countries. This is popularity for being reliant on foreign trained health workforce, or is a popular country receiving requests for recognition of qualifications from health workers from other countries. In general, we also see an increasing reliance, a general increase in reliance over time, looking at these past 10 years. And from the regulated profession database, we can actually identify hints towards, are there two compounding patterns at work? Do we see that there's mobility from Eastern and Southern Europe towards Northern and Western Europe, and then also mobility within Northern and Western Europe? And both of these patterns may compound this health worker distribution across Europe. And then lastly, we see that magnitudes of outflow are higher in some Eastern European countries like Romania, Estonia, Hungary, Slovakia, and in Northern Europe. European country in there is Denmark. So in this process of making these diagrams and analyzing this data, we also reflected on some of these gaps that we identified in this data. And we can identify, in some cases, some inconsistency in indicators, or that there is data missing for certain occupational groups. For example, as I just presented, I presented on doctors and nurses, while also medical assistants, health assistants may play a significant role in this health worker mobility, but they're not reflected necessarily in all of the data, as well as some missing data for countries and over time. Some important nuances, as I said, nuances to indicators. So these recognition of qualification might say something about intention to leave and not necessarily about the reality. And then there is proportion of foreign-born and native-born health workers among the foreign trained. Another data gap that I think is interesting is this limitation, the limited disaggregated data that we see that's available. So a limited disaggregation for sex or gender, ethnicity, also think about disciplines or actually years of experience. And with that, this question of who these migrating workers are and perhaps what they need is challenged. We actually don't necessarily know. And at the same time, we see that there's limited connections and integration of different level data, such as international, regional, and national data. Wrapping this up, I would like to end on some of the unfinished business that we identified from this analysis, which is the need for reliable and comprehensive data, including this disaggregated data, including aligning indicator definitions, aligning methodologies between countries, also to actually closely monitor gradual changes in mobility, as well as the types of mobility and the mobility routes, as we do see that there's differences from which countries nurses or doctors seek to get their qualifications recognized abroad. They may seek to get their qualification recognized in certain regions, while this may be different between doctors and nurses, for example. And to ensure a coordinated response to this health worker mobility, we also identified the need of integration of international, regional, and the national data. So this was what I wanted to present regarding some of the key findings. Of course, it's a more nuanced picture, and more information and more data can be found in the report, which can be found on our website. But this is what I wanted to present today. So I'm going to stop sharing. Thank you for your attention. At the same time, I want to remind you that if you have any questions, you can put these questions in our Q&A box. But before I will have a look at the box, I want to begin with the next part of our webinar, and that is the panel discussion. So with that, it is my great pleasure to introduce and welcome Mr. Gaetan Lafortune and Professor Ellen Poelman. First, a welcome to Professor Ellen Poelman. She is the president of the UvA Section Health Workforce Research and currently interim professor of health and health systems at the University of Siegen in Germany. She has a background as a specialist nurse, and her research focuses on health systems and policy, the health workforce, and gender inequality and gender equality, and it's based on a strong interest in international comparison and global health. So welcome, Ellen. Thank you for joining. And then I also want to welcome Mr. Gaetan Lafortune. I'm very happy you joined us today. He's a senior economist in the OECD Health Division. And for many years, Gaetan has coordinated the OECD publication Health at a Glance, more recently focusing on the European edition of this flagship publication. And he's one of the main authors of various key publications, including OECD's recent trends in international migration of doctors, nurses, and medical students, and more. So very, very warm welcome to you both. As we just reflected on a key insight in the status of international migration and some trends, I would like to begin our panel discussion to ask you both, actually, before we discuss some of the gaps, to reflect on this data presented and what, in your view, these key recent trends tell us regarding the maldistribution of health workers across Europe and what we should take from this data. So in short, it's a reflection on the progress made and on the question, and now what? So Gaetan, I'd like to start and open the panel with you in regards in the context of your experience also with the health workforce migration module in the OECD. Could you share some of these reflections with us?
Yeah, okay. Thank you very much, Marlies. First, let me congratulate you for a very good report and for a very good presentation of this report. And you are obviously dealing with a very important topic, the topic of the migration of health professional doctors and nurses. This is, you said that you are limiting more or less your analysis to Europe, but obviously this is an issue that goes much further than the European borders. And I'm going, like, if you allow me, I'll just present a few slides to say that in the data that we collect with the Eurostat and WHO Europe on health workforce migration, like we collect data not only about movement in Europe, but also movement around the world, because some of the most some of the countries with the least number of doctors and nurses are outside Europe, and they are also those who are most threatened by international recruitment from either EU or OECD countries. So not a new phenomenon, obviously, like the migration of health workers, but as we have documented, because the OECD has followed and has monitored these migration flows for a long time, like this, the number and share of foreign-born and foreign-trained doctors and nurses has increased in many OECD countries over the past decade. It will be interesting to see what happens in the current decade, whether either the pandemic or the aftermath of the pandemic and the structural issue of the growing demand for doctors and nurses may accentuate like the interest of recruiting people from other countries. There are also interesting issues, and if you allow me to go through this, like I will go in through also the composition, because the numbers are growing, but they're growing at different rates in different parts of the world. And then I'll close my intro remark there. But if you allow me, I'll just mention a few more words about the data, and just go a bit deeper in terms of what the data can tell us, and then go also into like the so what question that you've raised with us, which is like what type of policy responses may in particular address like some very serious concerns about the countries of origin that may be losing like a large number of their scarce health workforce resources. Over for me for my intro remark.
Yes. So then I want to invite Ellen to reflect, and then I am happy to go to your slides after that, Gaetan.
Yeah, many thanks also from my side. Apologies for my voice. I'm struggling a bit with a cold. So at first also many thanks for raising this issue, because my initial comment would be, I see the biggest problem with the health workforce migration and mobility data, that there is not an adequate political will really to invest in this area. And Gaetan will say more on this and knows much better, but I think there has been great progress over recent months, even with WHO and OECD. But what I really miss is this political will to invest more in this area, to integrate the question of foreign trained or foreign born, whatever, healthcare workers in all areas of the health workforce. And I think COVID is a really crucial event that showed us how important the migrant health workforce is, and it even increases. And at the same time, it is absolutely shocking that we have really no data, with the exception of a few countries, but we have really no data on the situation of migrant healthcare workers during COVID-19. And at the same time, we know very well that COVID has dramatically increased the social inequality. So this is for me really one very, very important issue, and therefore I think every effort to bring this topic on the table, is a step further. And I see problems on many different levels. It is always difficult. You can always say we don't have enough data. I think that's important for every question. But for the migrant health workforce, I really see these problems. That is not clear what we are actually talking about, because there are different categories. Gaetan mentioned that. Unfortunately, there we now at least have for several countries, not for all as far as I can see, this differentiation between foreign born and foreign trained, and sometimes also data on the inflows and outflows. But for me, and that also follows from what Gaetan already mentioned, for me the challenge is really to respond on a data and research level to what is actually going on the level of health workforce policy and recruitment, and also on the level of globalization and mobility. Because I see that there are many different ways, many different forms of mobility, and this old idea that we have migration, people go from one country to another and we can document that. That is no longer sustainable, I think. And also now EU countries like Germany, they are trying to recruit from outside the EU, where they see a much larger market, and at the same time where the restrictions are not so strong. So this is really a big challenge, I think, to respond to this mobility, because mobility as such is very difficult to measure. Then the other question, maybe I have a chance to say a little bit more on that. Based on data from a German project on migrant healthcare workers, we saw that is kind of the patterns or the motivations for mobility are kind of complementary. The reasons that brings people out of a country, for instance, saying so the medical services are very poor, the education is very poor. On the same time, they go to a country where they say, so here the education is better, therefore I go. And there's kind of complementary within the European Union, which I think refers to health system issues and brings this idea of European action and more solidarity-based action to the table. So that's it for the moment. Thanks very much.
Thank you, Ellen. Yeah, thank you for referencing this action and also the political will that we need, as well as the data gaps, some of the data gaps that you shared, which we'll get into indeed a bit later in the panel. So, Gaetan, can I invite you to share your slides that you prepared and your reflections?
Yes, thank you very much. And I don't want to take too much time. Can you hear me? And can you see the slides?
Yeah. Perfect.
Yeah, okay, everything is going all right. That's tremendous. Okay, I just want to spend a bit of time to talk a bit more about data sources, because the quality and the relevancy of the data is obviously based on some data sources. Like there are no data without data sources. And so I'd like to say a few words about the strengths and limitations of various like the main data sources on health workforce migration, and then I'll conclude with the policy responses. So there are three main data sources, at least three main data sources, just to simplify a bit the discussion. And the first two are the two that you use, Marlies and your colleagues in your report. So there's the OECD Health Statistics Database that report data on the joint questionnaire that we've had since 2015 with Eurostat and WHO Europe, and which relies mainly on national professional registry. So this gives you data on the number of foreign trained health workers, like we're focusing on doctors and nurses who have moved and who are working in countries of destination. Then there is the European Commission regulated professional database. And as you mentioned, Marlies, these data relate to people who are seeking a recognition of their professional qualifications, like people in various countries. So it's a signal of an interest, an expression of interest to possibly move. But people have not moved yet. Like this is the first step. Like for doctors and nurses who want to move, like the first step will be getting their professional qualification recognized, which may be automatic within the EC. But then there are various steps within the process of that may or may not lead to an actual migration. And then I'm just mentioning here like a third data source that we're using, which our colleagues here from the immigration division at the OECD are doing, which is a database on immigrants, which is using population census data or labor force service data, and they focus on foreign-born. And I don't have the time now too much to go into the advantages of going into foreign-born versus foreign-trained health workers, but I'll say a few words a bit later on. Okay, so our annual data collection with Eurostat and WHO Europe. So we focus on the place of training. So meaning where people got their first diploma in medicine or in nursing. Then we do distinguish between foreign-born from the domestic or native-born foreign trained doctors. And this is important, and I'll show a very striking example a bit later on of some countries where, in fact, most of the foreign trained doctors are, in fact, like people from the country who moved out to get their medical education elsewhere and then came back to practice in their home country. Then we are collecting data on stock and annual flows. Like this is very useful. Stock will give you an idea of the overall reliance. You showed the stock data in your presentation when you showed like the evolution between 2010 and 2021. By definition, it will be more stable than the annual flows, which may move a bit more. Then we collect immigration data from destination countries by all countries of origins, and I'll show this. And this is not only European countries, like we're including all the countries around the world from which doctors and nurses may be coming from. And then we're able to describe immigration pattern through the aggregation of the immigration data that we're getting. And I'll show a concrete example. This is, sorry for this table. This is just to show you like one example of the data that we collect. This is the stock of foreign trained nurses in the UK. So this is the Excel table that we receive from countries that are providing us the data. The only exception is here I've only selected the top 20 countries of origin of the foreign trained nurses in the UK in 2020. So by far, like if you just look like if you look at the first two countries of origin, by far the first two countries are Philippines and India, like by a huge margin. But then there are also like in terms of stock, there's also a large number coming from Romania, Portugal, and Spain. Now, if you use these data, like I've used these data here to show the trends in terms of the inflow. Now we're moving from stock to the inflow. The inflow by definition will be more sensitive to particular situations. In this case, the Brexit vote in June 2016, which has affected the number, but also greatly the composition of the new foreign trained nurses that are coming in the UK. So up until the Brexit vote, like the numbers were growing, like the nurses were recruited from other countries, but the biggest share of the nurses were coming from other EU countries. Now, after the Brexit vote, there was a sort of a huge reduction in the inflow of foreign trained nurses. It has started to increase in recent years, but most of the inflow have not come from EU countries. They've come to a large extent from two Asian countries, Philippines and India, and they've come also from other countries. And here, like I was not able to isolate the countries, but many of these nurses have come from African countries and some countries also in Asia. So you can do this with the data that we collect from the UK or from other countries. You can do either like analysis in terms of specific countries of origin or grouping of countries of origin. Now, This is the very interesting thing about this data collection, which is that we are able to monitor the immigration, the outflow, by using the immigration data that we get. And unfortunately, we don't get immigration data from all countries, which is one of the unfinished business, to use your word, Marlies, in terms of our data collection. But what this shows you is so we're flipping around like the immigration data, and then we're looking at the outflows. So this is the flows. This is not the stock per year of nurses who have moved, who have been trained in Romania and have moved in other OECD countries. And I've highlighted here like the countries with the biggest number. And so if you look at the UK, up until around the Brexit vote, like the numbers were going up like crazy. The number of Romanian nurses moving to work in the UK. With the Brexit vote, this has put more or less an end to that movement. And now, like in Italy, Italy was also like about 10 years ago, where a country where there was a lot of nurses moving to work in Italy. It is sort of slowed down, but it is picking up a bit slightly. And now the main country where Romanian nurses are moving is Germany, with the number increasing quite a bit. So you are able to do this to the extent that that we're getting data from the destination countries. And there's an option, like if you use the OECD health statistics, like you just need to change the setup, and this will give you this table automatically. Now, the strengths and limitation of various data sources. The regulated professional database is that like it provides data on doctors, nurses, and other health professionals who are intending to migrate. So that's useful. It's an intention. The data is easy to collect and to compare in Europe, as you've done in your report, Marlies. And the information will always provide the information on the place of education and training. The main limitation is that it does not tell you whether the health workers have actually migrated. Because it's, as I already said, the recognition of professional qualifications is the first step in a process, which includes many other steps. Like it includes also, like before people will move, they may have and be able to work as a doctor or nurse, they may have a language test to pass. Like if they want to go to the Netherlands, for instance, or to Denmark or Sweden, they will have a language test to pass. Then they will need to get a job offer. It's not enough to get your qualification recognized. You need to get a job before you're going to leave your job in most cases. So so you don't get this. Then it does not provide data also on where people will end up going, to the extent that they actually move. And then it does not cover also other popular destination countries in the OECD outside Europe. Like I'm mentioning here, the USA and Australia, Canada. And like obviously, like doctors and nurses from EU countries who want to move there may also try to get their professional qualification recognized in these other countries. Now, strengths and limitation of the joint questionnaire that we have with Eurostat and WHO Europe. The data is looking at the actual migration. So it's not intention, it's actual migration based on the place of training, which is arguably the most relevant variable if you want to monitor the brain drain. It's based on the national data sources that are used to provide these data, often provide both stock and flows data. And I showed some of the example. It covers all countries of origins, not only the European countries. And as I showed, the aggregation of immigration data allows a monitoring of immigration patterns, which is always the most difficult. Like countries usually know if doctors and nurses come from other countries, but often they will not know if some of their doctors and nurses are moving out and are starting to work in other countries. Now, the limitations is that we don't have data available from all countries of destination. It's not absolutely required that we get it for all single countries in the OECD or EU or in the world. The main thing is that we need to get the data from the main destination countries if we want to be able to monitor immigration outflow patterns. And then there's the issue that the foreign trained health workers are not always immigrants. So this issue of foreign trained but native born doctors, which do not reflect, like if you have people like, I'll use the example of Norway in the next slide, but if you have Norwegian students who are going to study medicine in Eastern Europe or in other Nordic countries and go back to Norway, this is not really brain drain. Like this reflects another phenomena that we've called the internationalization of medical education. And this shows like, this is breaking down the data that you showed, Marlies, on the share of foreign trained doctors in Norway and the UK, but breaking it down between the foreign trained and foreign born. So really the foreigners versus the foreign trained and native born. And so in the UK, the vast majority of foreign trained doctors, here we're focusing on doctors, not on nurses. About 99% of foreign trained doctors are foreign born. So like, let's call them immigrants. In Norway, it's not the case. Like the majority of foreign trained doctors are in fact Norwegian students who went to study abroad and then came back. So they're listed as foreign trained, but native born in our database. So that's an important thing to keep in mind when using our data. Now, I have only a few minutes to go through the possible policy responses to mitigate the negative consequences of health workforce migration on countries of origin. I will mention three policy responses. The first thing is a do not do. Like it's and the do not do is to avoid active recruitment of doctors and nurses in countries that have the most severe shortages. And this is a fundamental principle of the WHO Global Code of Practice on the International Recruitment of Health Personnel that was adopted in 2010, that countries should not actively recruit in countries with the most severe shortages. WHO came up a couple of years ago with an updated list of 17 countries worldwide that have such severe shortages and that are requiring what WHO calls health workforce support and safeguards. But the overall message is that countries should not actively recruit, like that it is not ethical to actively recruit from these countries. Most of these countries are in Africa. There are also some in Asia, one in the America. But you have a link to the full list of 47 countries where countries should not actively recruit. Then there has been also a movement to try to promote bilateral agreements which may be mutually beneficial for the health workers who are moving, for countries of origin, and also for the destination countries. And we are about to release a review of 37 bilateral agreements on health workforce mobility. The findings from this review is mixed in terms of the results and positive and negative results. Like I haven't been directly involved in this work, but one of the first findings is that in theory one would expect the Ministry of Health to play a critical role in these bilateral agreements, but often they're not involved. Then there's also the destination countries also tend to have an advantage in terms of the negotiation and the implementation of these agreements because they have more power than the countries of origin. The evidence in terms of the benefits for health systems in the countries of origins are often not identified, not clear. On the positive side, like there are an increasing number of these bilateral agreements, like incorporate some clause about the respect for health worker rights and well-being. And then there's a lack of data in terms of the implementation of the agreements and their evaluation and impact. The third and last policy response that is a broad one, but migration is the result of both pull and push factors. Pull factors from destination countries who are seeking to recruit workers from other countries to fill their domestic gaps, and also push factors, which reflects the fact that the working conditions of doctors and nurses in many countries are not great. And so the workers are legitimately looking for either better pay, better working conditions, better safety at work. And so it's a shared responsibility in a sense. The first responsibility has to come with the destination countries and making sure that there's enough training of doctors, of the nurses and so on, to reduce the reliance on international recruitment, to also improve the working conditions, to increase retention rates, which is a big issue now, particularly for nurses, because if you have many nurses leaving the profession before retirement age, and you don't train enough to replace them, then you will need to recruit some from abroad to respond to the demand. And then there's also a push factors, like to address the various issues that are pushing health workers to migrate. Okay, that's it for my presentation. Thank you very much for allowing me to share this slide. And over to you, Marlies.
Thank you, Gaetan. Yes, thank you for also your added context to this data collected and some nuances to this data as well, from the perspective of the joint questionnaire, also in regards to these outflows, right, per year, and the country differences relating to some of the policy options. And then I would like to zoom in a bit on the data gaps, and for that I would like to reflect with you, Ellen, because in one of your papers, A Call to Action to Establish a Research Agenda for Building a Future Health Workforce in Europe, you also reflect on some of these key data gaps, right? Important data gaps as poor integration of data, potential regional sources, wide variation of indicator definitions. And in my analysis, I also stumbled upon the fact that this data is not disaggregated often. So I was wondering, who are these migrant health workers? Who are the people that are migrating? So I was wondering if you could reflect a bit on the value you see for this disaggregated data, and as well some of the key barriers and opportunities for collecting this type of data, and maybe how this relates, again, similar as to Gaetan, to some policy implications.
Yeah, thank you very much. Marlies, I think, so at first I must say these questions are by far too broad to be able to respond to that in 3 minutes or so. Therefore, I would like to focus on a few issues. At first, of course, it is always important to have data because without data, it's very difficult to persuade policymakers. And there is a great progress that we now have better and more differentiated data. As Gaetan has explained in more detail. And also, I totally agree that in future, it would be very helpful to expand from nurses, to expand the focus on doctors and nurses towards other groups, especially, I think, carers. Because carers are in European countries, in many European countries, a very large group, and our knowledge about carers is very, very pure. But at the same time, I would like, in relation to the data gaps, I'm trying to be a bit complementary to what we heard on the data source issues. And as I said, in terms of time, I feel I can't comment on all the questions. I would like to highlight findings from a very small qualitative study that was funded by the German Alliance for Global Health Research, and has finished very recently, where we had a look at Romanian doctors in Germany that are the largest group of doctors in Germany, and we did this with our collaborating partners at Cluj-Napoca University. And there we had a look at the mobility patterns from the individual perspective, as you asked me, on the healthcare workers, which I think would be useful complementary research to improve databases, to know what actually and why are these people mobile between countries. And first, we really found it is a process, even for those who are in Germany since years and who feel themselves very well integrated. Some are married, have children, and so on, but still they feel it's a kind of process. Some said a door is always open or so, or one suitcase is always packed. And that is one important conclusion to get a better understanding of health workforce mobility, especially within the European Union, where we have these no legal restrictions as a process, really. We found that also one pattern which Gaëtan explained as internationalization of medical education, we called it the mobile citizen. And these were also not only students, but doctors who said they feel as European citizens. So they go, they are highly motivated, they want to learn for themselves, and they also want to live, and they go where they have the best opportunities. And they don't feel anymore that they must say, I'm a German, I'm Romanian, or an Italian or so, but they enjoyed this kind of mobility. And the other important pattern was that I already mentioned, with this door is open, that was those who said, I'm happy here in Germany and I enjoy that, but. So they also, there is an interest to reconnect to Romania, and some also said they feel they would like to give something back also to Romania, because they feel they are much more needed there. So and then we also, of course, had a very, very, very small group that said they want to go back to Romania, which is clear, and then also small group that is very clear they want to stay here. In Germany, they are so long here. But the interesting thing is this larger group. I mean, it was qualitative study. We shouldn't argue with numbers, but there were large groups, and there were interest in this exchange, whether we call it circular migration or whatever word we use for this. And for me, that would be now, because the time is over more or less already in terms of policy, I think they could be an interesting group for the future, because ethical recruitment is extremely important, extremely. And I think the code of the WHO unfortunately does not go far enough. We should really think of whether there are more stronger tools that we can use, which is difficult. But at the same time, the mobility within the EU is a high value. And we should think of how we can use this motivation of people to be mobile, to make experiences in many different countries, which comes close to this internationalization of medical education, but at the same time gives something back. And that's something which would be useful to put more thoughts in and more incentives, especially from the high resource countries, as Germany also. And that again is a policy issue, where I currently don't see sufficient will of the richer countries really to take responsibility, say, so we have made use of these foreign health workforce for our healthcare systems. Now we must take some responsibility to give something back to these countries. So that's for me the main message that I would hope for the future, that we go more in this political direction. And that means it might become a little bit inconvenient for richer countries to remind them on their responsibilities. So I stop with this, as time seems to be over. Thank you very much.
Thank you very much, Ellen. Yes, thank you. And thank you also for your reflections on, other types of research, the ways that qualitative research can strengthen our insights into these mobility patterns, and some suggestions for policy. I think there are some questions in the chat. We don't have time at this moment, but one of the questions was, are there a system in place to decrease this migration? I think both Gaëtan and Ellen gave some suggestions of policy options to manage this migration. Because I want to be conscious of time, and respectful to all your calendars. So if there's open questions, we will share at the end of this webinar a list of resources that are relevant, a list of resources that are referenced during the webinar. So some of the questions may be answered through that as well. Yes, and as I want to be conscious of time, I do want to wrap up today. So first of all, thank you, Gaetan. Thank you, Ellen, for your reflections, for also contextualizing some of this data, providing some nuance to this conversation. Thank you for your contributions. I also want to thank everyone in the audience who joined today. So as I said, there will be a recording made available for you. It will be posted on our website. So you will now see a screen with the link to the website if you're interested. So please check this out. So here, thank you for joining. This is a link to our website. I also want to reference, echoing, I think, what Ellen shared, that we are also as an alliance collecting some stories of migrant people, health workers who have migrated within the EU. So if you know people who have migrated themselves, health workers, if you know people who would be able to fill out this survey or participate in an interview, please share this within your networks. So please visit our website. And for now, I want to wrap up the webinar and thank you all for joining and wish you a wonderful rest of your day.
Thank you very much. Bye-bye.
Thank you. Bye-bye.